Thank you.
Thanks very much.
Right. Sorry, beg your pardon, Lord.
Careful.
So we will start with this briefing. Thank you all for coming, and I think we'll go straight into the integrated performance report. Thank you.
So, as always, I will. No, it popped open again. That's all right. Can you all hear? You don't want to? Do you want to come forward?
Yeah, we can come forward.
Come forward.
I can come forward. We'll all tread on your toes. I'll get my jacket so I don't leave without it.
Okay.
Thank you very much.
So we'll just pick up some of the key points. So starting off page 1.1, I'm pleased to say that the position for mortality remains green, so good clinical outcomes being evidenced. And as we referenced at the board meeting last time, we're doing an analysis focusing particularly on patients who died under our care in January, because we are cognizant that January was a very busy time, obviously, for trusts nationally, and as is always the case in January, we saw a spike in deaths during that period. So we've got an analysis being undertaken. If we move on to quality measures, you will see that there are two indicators that relate to stroke, which are red, stroke, amber. We've done an in-depth analysis of those, both in terms of the risk assessment for stroke patients and also how we manage our TIA patients. We know in terms of the former that we don't have adequate inpatient capacity for patients with stroke, particularly on the Epsom site, and particularly at times of peak operational pressures. And we have got plans in place to expand the number of beds we have to look after patients with stroke, really with effect from the 1st of April, which will mean that our patients are then able to be looked after for the vast proportion of their stay on the stroke unit. Clearly at the moment we prioritise the patients who are sickest in the very beginning of their journey to actually be on the specialist stroke ward. We're working with GPs to make sure that where it's thought a patient might have had what's called a transient ischemic attack, it's like people call it a mini stroke, whereas it's a warning sign, we actually want to see those patients very quickly to get scans done and to get on with early treatment. And we've identified an issue where GPs aren't always prioritising the way in which they're referring the patients, so we've got capacity to see them, but actually there's a delay in the referrals getting to us. So we've got a piece of work going on with GPs to make them very aware of that. In terms of the risk assessment for dementia and VTE, our whiteboards and our doctor administrators will start to hopefully show an impact in the next month and drive those indicators up. And then final thing on page 1.3 is that whilst we continue to be good reporters of clinical incidents, over the winter period, particularly when operational pressures have been intense, what has been more challenging is to complete those investigations within the timescale we'd like to complete them in. So we're working with the divisions and looking at how we can undertake investigations in a different way, potentially using a wider base of clinicians to undertake them to actually get them done in a timely way. So I'll hand over.
Excuse me, can we ask a question? I mean, okay, it says December 17, right?
Yep.
Okay, data to be confirmed for December 17.
Which,
no figures.
Which parameter?
Risk assessment stroke.
Right. Yes.
So there's no figures.
No. So there's no figures formally published here on this scorecard, but because this is an area of focus that we've been looking at, I know that whilst I can't give you a figure, be it 58% or 56%, I know it remained an issue in December. And that's why we've actually done a deep dive, firstly to make sure we're capturing the information properly, and most importantly to make sure we're addressing the issue.
Okay, I'll shut up.
But we can say for stroke that there's this thing called a SNAP, which is the overall basket of measures for stroke that gives you a rating of A to E, where Epsom was E, which is the
Yeah.
bottom, for the vast majority of the last year, because we simply didn't have the
Yeah.
staff to meet the standards. And in the last quarter,
So-
where we've been given more money by the CCGs to invest in the staff that we need, we've got the overall SNAP rating from E to C. And the target for next year is to get it to be B. And if we can get it to be B, I think our chances of explaining to the CCGs why would you decommission the hyperacute stroke unit from Epsom if we can deliver a standard of B, massively improves our chances of being able to keep the service at Epsom for rather longer than they wanted us to.
Didn't CQC say that the Epsom Stroke Department was the fourth best in the country?
No. Definitely they did not.
Oh, well, yeah. Somebody's really wrong
The Sandra, are you filming us? You know that we have a thing that says we're not allowed to film the meetings because there's a camera.
There's a law that says we are allowed.
So we have this conversation nearly every time.
Sorry, can you explain why we can't? My understanding is that as this is a trust board meeting in public, we are legally allowed to
Yeah.
film. Can you explain to me why you think I can't?
Because it's at our discretion as to whether you can film or not, and we are filming it. There's a camera right behind you, and it will go on the website. So our ask to you is, please don't film, because if you are going to film, we're going to ask you to leave. Or alternatively, we're going to not do the public briefing.
And can you just tell me what the basis of you stopping me is?
Because there
we
isn't.
don't believe this is legal.
So the basis of stopping you is that this is our property. Our rules say, as an NHS trust, we can decide who films, and we have decided that we don't want the public to film our meetings because there's a camera right behind you where we are filming it, and we will make it publicly
What
available.
is your objection to our having possession of a film?
Our objection is that you could use the film for your own purposes in a completely selective way, and we don't think that's appropriate.
But, your last video was selective in that the questions from the public were utterly inaudible. And you're not the only body that has put out incomplete records of your meetings.
So we can waste the rest of the public briefing having this conversation
This
about
is important.
filming. Well, it's
You are supposed to be briefing the public. How many members of the public are here?
1, 4, I don't know.
I'm respectfully asking you to turn off your
Well,
phone
I will
for
stop
briefing.
now, Daniel, but we will look into this because our understanding is that the law says that the public and the press are allowed to record, take notes and film a public board meeting.
So
we will look into this, Daniel.
Okay.
I'll stop for now, but I think you're wrong and I don't think you're allowed to stop us filming.
Okay, thank you very much.
So where do I find Snap then?
So that is all nationally published data on the Royal College of Physicians website.
Bloody hell.
But we'll send it, or we'll find a way. I think we should just include it in the scorecard. It'd be easier. It comes out each quarter.
Should we catch up afterwards?
Yes,
and
okay.
I'll work out a way of getting it to you.
And just turn the page, and it says, bloody hell, I've turned 2 pages. It says at the top here, the first item is number of incidents. Same figures as December. Exactly the same figures as December.
In terms of the total numbers of incidents?
Yes, total trust incidents 1237, same as in December, 1237. Patient safety incidents 851, same as December.
That sounds like a good spot, but we haven't
Okay,
updated it.
I
then.
will have to go back because that is the January data. I mean, the data is very similar between months.
They-
I will
They
pick
can't
that
be
up.
similar,
Not
can
that
they?
similar.
I mean,
I'll pick that up. Probably.
Identical is,
Okay.
and the 634 under incidents reporting
Okay.
is the same figure as December.
Okay, thank you.
All right, I'll shut up now.
Shall I pick up? Excuse me. From safety thermometer, as you know, we didn't do the safety thermometer in January because of the pressures, but we've got it done for February and it is actually back up to 94%, and that will be reported next month. Our falls have remained consistently low, which is I'm very pleased about because the wards have been extraordinarily busy. From a staffing perspective on 1.4, which is the next page, we're going to change how we show care hours per patient day for next month. But 7.4 is the lowest we have been, and that's because we've got escalation wards open and staff are working across multiple areas. The night time is easier to staff than the daytime, so we've had some challenges with our daytime staffing, and that has meant that our ward managers and ward sisters have been in the numbers, as have our matrons and our clinical nurse specialists. The January recruitment is there. We had 26 RNs, and I'm now recruited and started in January, and I'm now meeting weekly with the recruitment team, and I'm pleased to say we've got 87 nurses and midwives in the pipeline due to start within the next 2 months. So we're managing that very closely. Moving on to infection prevention and control, we had 1 bacteremia in January, and that's because the patient wasn't screened on admission to the acute medical unit. So we've picked that one up in the actions. The hand hygiene numbers, the numbers of wards that submitted data again dropped off for January, and we've gone back out again to say this has to improve for next month, so I followed that one through. I'm pleased to say there's no CPE in the trust now. We managed to get the last one out last week, and all areas have been deep cleaned, so that's good news.
Mm-hmm.
Moving on to maternity care, I think what I would draw your attention to is severe postpartum hemorrhage. We're pleased to see that it's remained fairly low, the incidence of postpartum hemorrhage, and that's because we give the drug carbetocin to all ladies having their cesareans now, as opposed to just the emergency ones, so that's done well. I think that's all to say from my section. Would you like me to do friends and family, caring, patient experiences? We haven't got Lisa here.
Sorry, before you go on, could you tell me why the training on infection control is so very low this time?
Yeah, so that's because of the clinical staff, the doctors. We had a changeover of staff, and it wasn't recorded on Wired properly. So we've gone back and said, right, which areas weren't on Wired, and we're following it through with each directorate.
Can I say something about the hand gel?
Yes.
A lady came up and complained, and I think she was visiting someone with sepsis, I don't know, and she said she didn't see a hand gel machine down the corridor. When she comes up here, there are gel machines everywhere, and she said there should be one by the lifts because she couldn't gel her hands. I mean, I don't know why she didn't do it as she left the ward, but...
Yeah, so we don't put them by the lifts because we keep them as close to the patient as possible. They should be at the entrance and exit of the ward and by the bed.
Why have they got them? I don't know, I haven't looked. Why have they got them in the corridors
Because
here?
to remove them from here would have caused lots and lots of paint work problems, and the plaster would have come off, so we decided to leave them here. So it should be as you go into a ward and by the bed.
I mean, I don't know why she didn't do it on the way out.
No,
It's sensible, but...
Friends and family. So we have an improvement in the response rate for inpatients in A&E. Our challenge has been in maternity, and you may recall that in maternity we have to ask our ladies 5 times during their stay whether they enjoyed their stay with us. So we've actually decided to change how we do that, and Lisa's working with the company to change that so that we get our response rate up a bit higher. Health Watch, Sutton, are going to come in and work with us like they did last year actually to look at the experience of patients, and we hope to be able to bring that to a public meeting in the future as we did last year. The PALS response has improved really well. We're up to 2 days response within 100% of cases for January, and that shows how well PALS is working now. And similarly, our response time to the complaints remains high. The other point I'd raise, which is probably under me rather than Lisa, is our mixed sex accommodation. So during January and late December, we had immense pressures on the wards. So we did have to mix some bays, gentlemen with women. But we chose to do it in areas where the patients were dressed and going home the next day to mitigate it as much as possible. However, we have reported that data, and I've had conversations with the CQC and NHSI, our regulators, about it. On to Dan.
So cancer access,
We report a month in arrears, so this data shows for December, and you can see that we've met the standard across the board for all the cancer standards. It's probably worth highlighting that cancer demand for 2-week waits dropped slightly in December, and we're just tracking through what impact that will have in January. In terms of elective care pathways, it's probably easier if I do this one second, but we have seen a further increase in our backlog size for referral to treatment times. That has been caused in large part because we have taken people off planned clinical care activity to create additional capacity on the wards and to make sure that we can maintain patients coming in on non-elective pathways in line with national direction. So we've tried to accord with that. We have made sure that our diagnostic standard has come back up to its usual level of performance, and that's been really encouraging. It's demonstrated some good work that's been going across the board. In terms of length of stay, I don't think that's changed radically. Again, we'd have expected that to do so. We've changed the profile of some of the operating activity we've done, and therefore electively we wouldn't expect that to have changed radically. And I think it's a real testament to the hard work going on the wards, the number of 28-day breaches where we've had to cancel an operation on the day and then are unable to get somebody back in within 28 days for their operation, and the figure of 1 for January is a quite remarkable achievement in terms of the level of detail being undertaken. In terms of emergency care pathways, the next slide, we hit the standard in January for, achieved a performance of 89.6% for all types, which is not where we would want to be. I think it's important to highlight that downward trend has matched both London and national performance, and is despite the incredible efforts that our staff have gone to try and map that through. Non-elective length of stay has risen very slightly. I think that probably is now nudging towards statistically significant. We compared this December and this January with the same period last year, and whilst our attendances are up very slightly, what we have seen is a fair shift towards the more sicker patients who are coming in. I think the change in length of stay reflects that rather than anything else. Delayed transfers of care are down, and I think again that reflects a lot of work that's being done not just by us but by all our partners in the community to try and help us wherever they can, and they can do their bit by taking patients off us at the far end. And then finally on ambulance handovers, I think it shows that we are improving our performance at ambulance handover despite the increase in activity we've seen. Shall I pick up workforce? So I think the thing that we're really rather proud of is the indicator of the total clinical workforce, where we're now at the highest we have ever had. It's 3,374 for January. We're also below the agency trajectory that we have been set. But if you go to the second page of workforce, you can see that staff sickness in January was also the highest it's ever been. And that's a symptom of the really, really horrible respiratory virus, which has caused the whole increase in emergency activity. And surprisingly enough, the staff who work in the hospital aren't immune from it.
So does that mean next year, Daniel, that they'll have the extended vaccine available here in the hospital?
So we will vaccinate whatever we are told to do.
Oh, sorry, I went to a PPG meeting a few days ago, and so the manager, right, she told me they've already ordered next year's, right, the full four.
We're told around September which vaccine to use, and whilst we had very high uptake from our staff, this was not necessarily flu. There were flu-like symptoms.
Sorry, just wondering. I don't know.
Can I just ask a question? You were saying just now that you'd reduced or cut the number of planned procedures to cope with acute services during the pressure time. If you were to get your way and have all the acute services on one site, you obviously couldn't do that because you wouldn't have the different sorts of treatment in the same building or with the same staffing levels. So if you put all your acute services in one building, that flexibility would presumably be denied to you.
I'm not sure I follow because we did that.
During the winter you were told to stop planned procedures to free up room so that you could deal with the raised number of acute patients coming in as emergencies. If all your acute services were, according to the trust plan and the STP, to be put into one location, remote from the other hospitals, how would you then build in the flexibility to stop some sorts of treatment so that you could concentrate on the acute services? If your acute services are in one place with a fixed smaller number of beds, how can you expand your capabilities during a high pressure period?
No, they pretend.
Go on then, Ruth.
Now, what I was going to say, and I know we've discussed this before, is that the total number of beds would not be significantly different to the total number of beds now. And actually, we'd have patients and inpatient capacity across 3 different sites. So actually, that could afford potentially more flexibility.
But not for acute patients, because you won't have, presumably...
I think it comes back to a conversation we've had before around what's the definition of acute. So, as you know, in our proposal, we propose that there would be significant quality benefits in having the very sickest acute patients on one site, but there would be capacity for other patients currently admitted acutely to be cared for safely outside of that environment.
Well, Daniel told me that his plan was that at St Helier, for instance, you would keep 200 beds, and those 200 beds, Daniel, you can confirm you told me this, those 200 beds would be for patients not quite well enough to go home, elderly patients only, not quite well enough to go home. You presumably, therefore, wouldn't have acute facilities there. You wouldn't have the staffing to deal with a sudden influx of acute patients.
So I think Ruth's point is correct. That actually, if you built an extra 500 bed spaces for Epsom and St Helier,
It's not extra.
It's not extra.
but so imagine
Yeah,
that we've got to the mid 2020s,
I'm imagining.
right, and we've built a brand new 500 bedded block for acute patients somewhere in our catchment,
But
right?
not Epsom.
The somewhere in the catchment.
Epsom's part of the 3.
And we have kept both Epsom Hospital and St Helier Hospital open as hospitals.
Yes.
Yeah, we have way more flexibility to expand the number of bed spaces that we need. And because we've still got all the capacity that we started with.
But the acute
And
capacity.
but when you look at this is really important. So we're
Yeah, I'm listening.
going to do this properly. When you look at what has happened this winter, which is completely unprecedented in terms of the volumes of admissions, they're nearly all from old people, and the length of stay has gone up because the old people are coming in really, really unwell.
Yes.
And there's a whole piece of work we have to do to work out how did everyone get so unwell in the first place. And I think there's a lot we could do to have stopped so many people getting so unwell. But
Lack of funding, probably, Daniel.
but the length of stay has got to be over 21 days for a huge number of people. And in that 21 days, we've probably got 10 to 14 days of actually the people are genuinely medically unwell, and then we're on the convalescence journey. And so if we had access in extremis to open up more capacity for the convalescence part of the pathway, which in our model we think we'd actually end up with a much bigger flexibility to do, I think you'll find that we would have managed this influx of patients more easily than we have currently done.
But Daniel, you just said that they are unusually extremely sick, this bigger cohort that's
Yeah.
come in this winter. You also told me during that same conversation that you would discharge everyone that wasn't elderly after 3 to 5 days in acute care. Therefore, you're looking at 3 to 5 days of really sick people. And if you've only got the acute facilities and the doctors and the surgeries and the medicine concentrated in one place, you will not be able to miraculously expand that capacity to another building that is only built to serve as a convalescent home for elderly people.
So let's see if
Yeah. I think there's 2 conversations here. There's one about beds,
Yeah.
and there's one about your challenge coming from something I said. And I said we'd reduced levels of activity in order to put more people onto the ward care for our
Yes.
inpatients. that activity is not in itself always inpatient activity. So we have cancelled some of it. Well, some of it is surgery, and we've used surgical capacity. Those surgeries are not always for acutely unwell patients. They're for patients who can come in at any point in a range, so we can move that across the range, as Daniel has said.
Yes.
But the point about one site, we would be no different on one site to many other one-site trust hospitals. If you take down a clinic in Leatherhead because you need to use that doctor somewhere else, they are able to drive. Frimley Park Hospital, just down the M3, has satellite hospitals which it visits. It has pulled clinicians in from them doing outpatient clinics to support people on the wards, and we would behave in the same way. So I think there are two conversations here. There's one about beds, and I completely accept the point about convalescence, and you see that. There is a second conversation about, it's not about the sites, it's about where the doctor or the nurse specialist would work, and they
But
can...
if they're working on your specialised isolated acute centre and they're overstretched, they're so overstretched that you have to stop other treatments, they're not going to be free to go to St Helier or Epsom to treat equally acutely unwell patients, are they?
So then there are two next bits of the argument. That when your staff sickness levels go up, as ours have done, we have found it almost impossible to staff the acute services spread across 2 sites. We've had lots and lots of gaps, and lots of people doing jobs that is not the job that they've had to act down to get things done, right? That means that can you shut the door? That means that overall we have become less efficient because
we probably need to employ more staff and stress them less by overworking.
So that comes to the whole premise of our clinical model, which is unless we can get our acute services consolidated into one place, we can't recruit the staff. They are not out there to be recruited. And it doesn't matter whether you try recruiting them from Europe, you try recruiting them from the rest of the world. There simply are not enough clinicians who have been trained to fill in all the rotas that we need. So that's one point. The second point, which is where I think you will now actually agree with me, is that we do have to step back after this winter and look at the overall bed numbers that actually exist in the NHS, because no one has coped brilliantly with this huge increase in activity, and we have to work out as the NHS what is the level of resource that is needed to properly deal with this kind of thing if it were to happen again, because we have put a lot of patients into they have not been through the most ideal pathway. A lot of staff have worked extraordinarily hard in circumstances that aren't ideal.
Lots of people have died.
And the NHS needs to do a whole, let's see what is actually needed for going forward.
To stop spending 300 or 1000 or 30 or 10 billion pounds a year, letting contracts and outsourcing, start spending money on the NHS, and then you might be able to.
Okay. So just to finish off the IPR, on the money.
You still haven't answered how you're going to expand your acute capacity. You will have no acute capacity here, and if you've got an excess number of acute requirements over and above that available at the single site, you haven't got the ability to expand your acute capability.
Okay, so I think we just answered.
No, you haven't answered it at all.
So I'm going to finish off the IPR. So so on the money page, we are more or less on track. This is what the money indicators show. But because we haven't achieved 95% for A&E for quarter 2, 3, and now quarter 4, we will not get the STF bonus for A&E. So we are showing that we are going to miss the control total by that amount of money. So that's it on the money page. Then on the risk register page, the one risk to highlight that has changed considerably is we now have a risk that is at 25, which is the highest risk that you can have. So 25 means it has happened and it has a big consequence, and that risk is about our capability and capacity to deal with everything that is required us to do, because the sheer amount of energy being expended on operational management to deliver a safe hospital in all this pressure has meant that lots of other things haven't happened in the planning as they should have done. So that is the one risk to highlight. I think that does the performance report.
That's fine. Do you want to do your strategic update?
So strategic update.
Thank you.
Well, the place to start is it's been very hard to do strategic stuff in the last few months because the operational pressures have been very, very extreme. I think that the thing that I'm really keen that we celebrate is just how hard our staff have worked to keep people safe. We had an extraordinary Winter Heroes event last week where we gave awards out to well over 100 members of staff who had been nominated by other members of staff for doing extraordinary things to keep people safe. And Jeremy Vine, journalist extraordinaire, or presenter extraordinaire, came and compared the event. And he told us about his father, who we are looking after, and about the great care he had had, and about how amazing he thinks Epsom and St Helier is. All in all, I think it was really important to recognise the huge contribution that our staff have made. And I don't think any other hospital around has organised an event specifically to recognise people for the winter in the way that we did. So I think that was a really good thing. On the strategic update bit, though, the two things I would highlight are the Surrey Downs CCG has now awarded its contract for community services starting in October, and I'm delighted to be able to say that Epsom and St Helier is the host of the community services going forward, but it's a really exciting partnership between us, the current provider, which is Central Surrey Health, and the 3 GP federations in Surrey Downs. And we are going to have a completely new model of care, which is all about integrating primary care with community care, than the hospital reaching into localities in Surrey Downs, with a big focus on keeping people healthy for as long as possible. So really proud about that. We've also got the Sutton Health and Care, which is the equivalent to what was Epsom Health and Care, which is a really big investment in a new team of people to respond to people when they become unwell in Sutton. Will go live in April. And that involves us, the London Borough of Sutton, the GPs in Sutton and South West London and St George's Mental Health Trust, with the Marsden playing a supportive partner role with their community services.
Is this an ACO by another name?
No, this is creating a single team of clinicians to respond to people who are acutely unwell and seeing if we can provide more services in their homes so they don't have to get admitted, and if they do get admitted, how we can reduce length of stay.
Is that not exactly what an ACO is?
No.
So is there no possibility that that could be at a later stage contracted out to a single provider other than yourselves?
The thing that we are pulling off in both Surrey Downs area and Sutton is that the NHS and local authority are working together collectively to pool our resources to create a single team of clinicians so that patients don't get stuck between silos of the different bits of the NHS and local government. And actually, we're trying to make what the public actually thinks should happen, which is health and care are joined together as a single thing, actually real.
But can you answer the question, is there a possibility that that could at a later stage be contracted out to another provider?
I would say we are doing everything that is possible to ensure that the local NHS and the local authorities are working seamlessly together to provide the best possible care for the residents of Sutton and the residents of Surrey.
But could it be put out to a private provider? Can you just give me a yes or no?
Well,
I understand you're trying. Could it happen? That will then be an ACO, would it not?
So I sincerely hope that it won't, and involving the hospital in it is a very good way of ensuring that that fear that you have cannot come to pass, because hospitals are not procured. Because hospitals, we have an annual contract with the CCGs, which we negotiate every year, and you can't really change that. So
No, but you could, presumably, other areas are in the process of starting in April, and I understood our area too, starting in April, a system where a single provider is in charge of producing and providing all the treatments, either for the whole area or for specific treatments within that area. And that could go out to a private company for a contract. Could that happen as a result of what you're now doing?
So what you've got going on in Sutton and in Surrey, our part of Surrey, is all of the providers working together as a consortia, as an alliance, to say, we think the best way of providing integrated care is that we all work together. That is what we are doing. So if it involves the hospital, no, it can't.
No,
because
not if it involves them. If a private contractor is then employed to do the job,
but
the hospital is completely.
But in Sutton and Surrey, there is no private contractor being employed to do it. It is the NHS, and at the moment is a pretty good start because that's what's happening in April, and the bigger success we make of it as the NHS and local government working together, the very much more likely that's how it carries on. So
it could happen.
So I'm very hopeful that that won't happen because that's not what any of us want to.
No, and I don't think anyone in the country was, and there's 2 legal suits going on at the moment to prevent that. But still, can you answer me? Could it happen? I get you don't want it to. Could that organisation that is just being formed in April, later, a year later, 6 months later, 2 years later, be let to a different provider than yourselves?
So as we have constructed it, no, it couldn't. Because we have voluntarily come together as all the providers, both across health and care, in both Epsom and in Surrey, to say, we can deliver you integrated care and joined up care so that patients actually get a much better experience by the NHS and local authorities working together. And as we have constructed it, what you are outlining could not happen.
So it couldn't be put out to contract in a year's time and someone else get that contract?
No. Not in the way that we have constructed it in our parts of the world, because we have all voluntarily come together ourselves to create a consortia to deliver great care.
But you will have to put it out to contract, won't you?
Well, we as providers don't have to do anything because we don't put things out to contract.
The CCGs.
So I think we're putting on the table to them a fantastic way of the NHS coming together to deliver what they need. So it's that is a question to them, not to me. I think we are, as a group of...
You know how the system works, Daniel. You know whether or not the CCGs, in some time in the near or distant future, could take that contract away from you and give it to, say, Virgin Care.
They've got no plans. They're taking stuff away from Virgin Care and stuff.
So as Lawrence is saying, Virgin Care are losing their contracts. They've only kept one in.
That was
Sorry.
an example. You're weasel wording now. That was an example. I know Virgin have sued Surrey CCGs, but that was just an example.
But in the Surrey contract for community, it's a 3-year contract we've just been awarded with a 2-year possible extension. The Sutton thing we have just setting up, Sutton Health and Care, is a 2-year contract.
Right.
And you'll discover that the Sutton one has not been procured. It has been negotiated with the providers. The Surrey one had to be procured because in the way the original thing was set up, it was a commercial procurement and had an endpoint. But we've now essentially brought it into the NHS because Epsom and Helier winning it has now meant that we're now back with community services being part of an NHS trust. So we're kind of all on the same page here, that we are working to ensure that the thing you say could happen won't happen in our geography.
Let's go on.
I need to ask you something relating to this. You've used the term providers, plural. We used to have an integrated NHS. It has been disintegrated. You're talking about integrating with social care, which is means tested. Who are the providers with whom you are dealing? Are any of them private companies?
No. So in Sutton, it's us. It's the London Borough of Sutton. It is the GP.
The London Borough of Sutton isn't a provider.
It is.
No, they may pay the bill.
No. So they are both. They are both a commissioner and a provider.
Yeah, a commissioner, but they don't employ
they do.
staff.
So they have 2 sets of provider services, one's that they provide themselves, and one where they pay for care in nursing homes, which is not part of the NHS or local authority. The bit that we are integrating with them is the bit that they provide themselves. And the bit they provide themselves is the reablement bit. It's the 6-week and they're all based here anyhow. So rather than all being managed by different people, they're now all going to be managed by one person who will join everything together. So it's us, it's the London Borough of Sutton, it is the GPs in Sutton, through the federation that they formed called Sutton, I can't remember, Sutton, yeah. And it's the Royal Marsden, and it's South West London and St George's Mental Health Trust.
You did just say that they employ contractors, didn't you?
Who?
Sutton.
The council? Well,
As one of your providers, you said they employ contractors.
they don't employ contractors. They pay for people to be placed into nursing homes, and nursing
So
homes.
those are contractors.
Well, nursing homes are private businesses.
Yes.
That's how social care works in the United Kingdom.
Yes, along with an element of means testing.
So there is some means testing. Yes, that's how social
So
care
you are
works
now
too.
Involving the NHS in a means tested system.
The NHS has been involved in a means tested system ever since social care was created, and it was means tested. But the reablement service, the first 6 weeks, is not means tested. It is for everybody, the bringing it together with our teams and the GPs and the Mental Health Trust will actually make the whole thing deliver lots more care for the same amount of money. In fact, we're going to deliver more care for more money because there's well over £1 million investment going into it from April.
Right, we've got to 10:15.
May I
Oh,
just add
yeah,
one
Dave,
point
yeah.
on that? This Sutton Health and Care is being run by an alliance of all the parties that Daniel has mentioned, and any decision that is being taken within that, every single party has a veto. And if Daniel says that the NHS will not seek to go privately in the future, then that kills it off straight away.
That is true.
No, it doesn't. Yes, it does.
So can I say something? I made a mistake earlier, and 2.2, page 2.2, we've got Jan 17 all the way. Oh, I got this wrong. I'm stupid. I said it already, didn't I? Forget it. I'm stupid.
I'm clarifying the dates, Bob, so I'll pick that
Yeah,
up
I've got
offline.
Jan 17 on page 2.2. So not Jan 18, but Jan 17. It's just a little slip of the computer or the finger.
Have you finished your strategic update? Is there anything else strategic you would like to talk about?
No. Unless is there something else? Can you think of anything strategic? What have I missed?
Well, I mean, nothing. I mean, obviously, I don't know whether you want to talk about or encapsulate. I mean, you've mentioned how difficult it was over the last 3 months in terms of just managing the flow. Whether you want to just sort of paint an overall picture of some of the things that we had to do and that happened, and some of the things that came out in terms of the way people talk, just so that everyone can get a flavour of exactly how challenging it was and how our staff were so brilliant by and large in rising to the occasion.
I can say so. It's been really difficult to manage the estates and to carry on working in a semi-building site at the same time, and the staff have done amazingly well. And basically, we've had to move staff on a shift-by-shift basis, and they've carried on uncomplaining. And doctors, including Dr. Marsh, who's not here, he's on his 15 steps, has gone round to the wards, seeing patients, discharging patients. Everybody have just been magnificent. I have to say, in 37 years in the health service, I've never seen anything like it. So I'm very, very proud of everybody.
Good, thank you. It really was.
I think we agree with that, don't we? I
We
don't
did.
know if anybody in the audience disagree with that.
No, and I think that, throughout the whole of the country, the NHS has really risen to the occasion, which is amazing, and have done a really exceptional thing. And I'm sure that as the next few months unfold, it will be very much understood more widely how the NHS has really sort of delivered in incredibly trying circumstances. So, good. Let us now turn to the feedback from the 15 steps which various people in the room have been taking. And I think, can we start with Sue and Elizabeth, who've been to... Where's Elizabeth? She was here.
Stepped out.
Oh, she stepped out, right. Well, let's, in that case, not start with Sue and Elizabeth. Don't worry, let's start with Rakesh and Richard, who have been to B5. Oh, they're all coming in now. We'll still start with Rakesh and Richard, who've been to B5.
So, Richard and I went to B5, which is a medical ward, 31 beds, primarily for elderly. It's a mixed ward with obviously segregated beds. As we walked in, the ward clerk, ward receptionist wasn't there, but she came soon after. The corridors looked well and not cluttered, but obviously there was a lot of activity happening. On the board, we noticed that the nursing numbers, what we should have and what we actually have, the poor ward clerk was in the process of fixing it. When we talked about the ward clerk and the nurse, and one of the nurses who was a bank nurse who just recently moved from another ward, it became apparent that every single nursing staff was either bank or agency on that ward, and there weren't enough of them as well. So there was an element of short staff shortages. The environment looked clean. It looked uncluttered. We found one of the clinical cupboards, storage rooms that was unlocked at the back. And I talked to a patient who'd been there for about a week, although she said it felt a lot longer than a week. And I asked her about how the nurses had responded to her needs, and she said they were really good. You know, she recognized that they were short staffed, but they always responded, they were courteous, helpful. The doctors always explained to her what was happening to her as well, and she gave an example of why she couldn't get discharged, and the doctor explained why that was. I asked about the food, and she felt the food was of a high quality. At times she felt she needed bigger portions. But generally, so that was the takeaway for us.
Yeah, I think the only thing that I would add to that is that this was clearly a ward that is under pressure in terms of numbers and staffing constraints. Yet everything came across to me anyway as a sense of calm professionalism. It wasn't panicked. And as Rakesh said, there'd obviously been change of shift, and people had been allocated to the ward at short notice. I was my interpretation, but it was just a sense of real calm professionalism in terms of getting on with the job. And in that context, against a ward which is predominantly old and very frail patients, and I think that came across very effectively.
Did you see any impact of the construction, because it's a B block, so it'll have scaffolding all around it?
The end of the corridor where it's taped off, and I think that all looked sensible and secure. It's Rakesh.
Okay, good. Anything else from Rakesh? Okay, thanks very much. James and Martin, you've been to endoscopy.
Yes, I'll start, and Martin made a few comments. We went to the endoscopy unit, which is on the 4th floor of A block. As we entered the area, there's a reception area on the right and some admin staff on the left. And actually people approached us to proactively ask if we could be helped in any way, so that was very encouraging. And then before very long, as we were walking onto the units, Louise, the sister, approached us, and she was very keen to show us around. We had a sense, it was the start of the day, so lots of people were not going through the recovery phase, but we were quite struck by how potentially busy they would be. But the staff there looked busy but very calm, and actually there was a sense of it was a happy environment, I'd say, in terms of a working environment. And the staff were very well attuned to the changes that were being undertaken to make the environment better for patients. Part of what we need to do is to get a national accreditation called JAG, and there were some changes that are needed to improve the environment and to improve the privacy for patients. And we went through the unit as though we were a patient in terms of the flow from the reception to the waiting room, to the consent area, to having the procedure, to recovery on a trolley, then sitting in a chair, and then having a consultation to let you know what would happen following the procedure. And whilst the physical layout of the ward is challenging, the team had obviously thought about that flow very carefully. One of the problems with the layout is that people who have had the procedure and been told what the procedure had found are then walking past people who are waiting to have their endoscopy, which is not ideal, but it's quite difficult with the constraints of the layout that we currently have. We then went up to the decontamination area and met by extremely enthusiastic team members who'd just taken delivery of a trolley to help load the endoscopies after the procedures. And one of them, Dante, was showing us his frustration with the trolley that they'd acquired yesterday, which didn't work well from his perspective. And he'd taken it upon himself to speak with the company that had supplied the unit and arrange for them to come to do a visit. And we were very impressed with the initiative he was showing. And up there, they seemed quite a content, happy team. Just a slight negative that I noticed was there is a friends and family box. I didn't notice anywhere, I might be wrong, about proactive display of what the comments were, except right at the back where the team do their huddles each day. And there was a you said we did comments, but it was a little bit buried.
Okay. Martin, anything to
Yeah,
add?
so I endorse that. I was very impressed by the calmness, the teamwork. It was clear that most of the staff were feeling pretty positive and confident. The trolley one I thought was particularly interesting because I was impressed by the fact that he was going to go directly to the manufacturer. He had that relationship. I thought he was going to say, well, I need to talk to Kirsty or something, but no, he was absolutely on it, absolutely determined to get it fixed. It was pretty ridiculous, not from the manufacturer's point of view, in that it was an obvious design fault. It just didn't fit. And that has a knock-on effect to staff, even potentially health and safety in terms of how to fix stuff, which was what it was supposed to be trying to avoid. And just one that I noticed as we first walked in, there's a data cabinet. It seemed to be all data rather than electrical, but even so, the cabinet was open, the glass door was open.
Great.
I should just mention, I did speak to a couple of patients who had just received consent, and they were extremely happy with the communication they'd had, and what I tried to press them about what we should be changing, they said nothing. So it was positive.
Good.
Perspective.
Thank you. Thanks very much. Sue and Elizabeth went to B4 Medical Short Stay Temporary Home. Hi, Elizabeth.
Shall I stand up?
Yeah.
Yes, this is a ward on the 4th floor of B block. So to answer your question about the impact of the new work, they have had their windows replaced, and I think they're still sorting themselves out a bit after that. That obviously caused a fair amount of disruption on the ward. It's a ward where typically people are only on the ward for 24 or 48 hours and works very closely with AMU in that respect. The physical environment is the most obvious thing that you notice. The ward is basically a railway carriage with 4 or 5 bays and a long corridor, which is very narrow, and it is very cluttered and cramped. We asked the ward sister, who was extremely helpful, Kirsty, we asked her to show us the clinical room, and she said, come with me. And we walked out of that ward, round the corner, into another ward, round another corner, kept on going, and eventually we found their clinical room. And yes, it was locked, and yes, the fridge was at the right temperature and everything, but it is a good 2 to 3 minute walk, would you say, Charlotte?
Definitely, and that's why it's temporary. They're going back downstairs.
It's really challenging in that respect. I spoke to a lady patient who was very, very complimentary. She had been in considerable pain yesterday, and she'd spoken to the nurses, and they had immediately given her some medication, and this morning she was much, much more comfortable. She was complimentary about the food, which is always lovely to hear. And we also looked at the things like the boards. The board for staffing on the ward was up to date, but I didn't have confidence that the Falls board and the CDIP and that sort of thing had also been brought up to date. And we did find that 2 drugs trolleys were not chained down, one of which was open, not locked. And Sue, do you want to say something about the staff that we spoke to?
Yeah, so I think my impression of the staff was they were all very friendly, very welcoming, very professional. Spoke to Kirsty, who's a new sister. She's only been there for 6 months. She was clearly the nurse in charge, wearing her badge. It was easy to identify. And she talked about how much she enjoyed being on that ward, that she didn't want to go on to her next rotational placement. She wants to actually stay with that ward because she's been so impressed. Spoke to a student on the ward as well, who said it was a very busy ward. He'd like a little bit more time with the patients, but he talked about it being a wonderful team, him being very happy there, and how supportive the staff were. I think my general impression was that there's good teamwork there. It was a very calm environment, and clearly good care for the patients.
Thanks very much. Yes, it was the drug trolley thing. You need to deal with that.
Yes.
Because that's a key issue. When it says medical short stay, are they people who are going to be coming in and then going back home, or are they people from AMU and then they're going to go into the hospital?
They come from AMU, but they're normally about 24 hours, quick turnaround, which is why we're eventually bringing them back down off the ground floor so they're adjacent to AMU when it's finished.
Good, thank you. I have Pat and Mary Moore.
Yes, I went to
Mary again.
which has been, is not the Mary Moore you might have seen before. It's all been renovated, all new, it is clean, bright. It still hasn't got natural light in all these areas, but that would be in a physical possibility, so we understand that. But it does feel clean, bright. It's, again, a rabbit warren, a bit like Elizabeth was describing, and I think that is quite a serious issue for a surgical ward, because patients are, some of them are quite they're quite recent post-operative, and they do want to use their cool bells, and if there aren't staff who are keeping an eye up to see what they need, then I think they can feel a little bit marooned. And I did speak to one patient who clearly did feel that. There is an issue about medical staff being in theatre and therefore patients not seeing their surgeon or somebody from the surgical team as soon as they perhaps might expect to. There were some really good things. I arrived as the whiteboard meeting had just begun. There was very good attendance from various therapies. There was actually a junior doctor there, although he had to leave later. And the nurse in charge, Sylvie, was going very thoroughly through the list of patients and what they were requiring today. I mean, I had to go away and come back because she was doing it so thoroughly. It took really half an hour to go through. And the nurses were then going off and doing, but she was going through all the lists of therapies. The VT was filled in on the board. There were only 2 which were queries. Everything else of the 24 they needed to take, so I assume they'd been done or didn't need it. The staffing board was up to date. There were a registered nurse down on both the shifts, the first 2 shifts today. And the staff were clearly busy. I think it is a challenging ward. Clearly, there are quite a lot of needy patients. And I can see how hard it must be to make sure that you are aware of what is happening to all of them in the more remote areas. Sylvie said that they are trying to have a huddle in the mid-afternoon as a sort of catch-up, which seems like a very good idea. It's a very tight environment. There was somebody coming out pre-op who was coming out on a bed, and an awful lot of things in the, you could barely get it out of the door and down the corridor. So I mean, there were clearly logistical issues which are just what they are. There was a phone and iPad left on a trolley at the far end, which I said pointed it out. I don't know who they belong to, but they were just sort of sitting there, which I was a bit worried about. And the fire exit at the far end was not clear. It had boxes and a chair in front of it, and there's also a toilet down there, which would have been quite difficult for anybody who wasn't pretty mobile to get to readily.
So are they going into the library?
Right down by I think it's beds something to 19 on the right.
Okay.
But it doesn't go into the library, it goes.
Does it go into the library?
No,
it goes to the right where the loo is.
Yeah.
And then there's the fire exit. So there was a lot of clutter down that far end. And you can quite see why, because of the way the food is. But, you know, the fire exit would not have been easy to access. I spoke to a couple of patients, as I said, and the main issue they came up with, if you boiled it down, was about communication. One patient, a surgeon who had not said that he was going to have to delay giving antibiotics because they wanted to do another test before he could put on the antibiotics. He would have understood, but he didn't know why, and hadn't been told. And another patient who had asked an HCA for something that only a nurse could provide, and the message didn't get through. So, I mean, it was busy ward, clearly, but communication came out quite strongly on a number of issues. So it's something we have to keep on top of, I think. Sylvie, the nurse in charge, said that when I asked her what she would like, she obviously has come down from B5.
Yeah, they all come down.
Yeah, so and it's a great improvement
Yeah.
to B5. So when I said, was there anything she'd like to see better, which would improve things, she actually didn't mention the things I expected her to say, but she said a private area to talk to families when there's bad news. They had a patient who sadly was bad news about, and they had to sort of search around for an empty doctor's room, or because the office was being used, and so on.
So when they knock through into the library next door, and that becomes the SACU, Surgical Assessment Care Unit, they've got a nice
there will be
room
oh, well,
just on the left.
That's good to hear, because I mean clearly there are people who are very sick.
And they'll be able to get in there really easy. Did she wear her badge? She was one of our winter heroes.
I'm afraid I
Just go back and look.
I said I might come back, so I can go back on. Not to me immediately, obviously. I mean, is it how large is it?
They're quite big. They're like prefect
I don't think
badges.
she was wearing it then. I'm afraid.
Oh, the word. No, she
I think I might have seen it.
Oh.
Thank you, Pat. And finally, Arlene and Ian went to, perhaps slightly unusually, the mortuary.
Yeah, so we went to mortuary. It wasn't really well signed, although I don't know that that's a bad thing. We went into the main building and they directed us out, security directed us out. We went through the wrong door, so we ended up pressing the bell on pathology, but somebody in there answered quite quickly and was really friendly and took us through the back corridor to the mortuary. There wasn't outside, which we then found was outside of the mortuary. There was a little waiting room set up. We found out later that that was set up because they have got a pop-up fridge where they would normally do the viewings, and so they've moved the viewing area into the chapel. So it was really, really clean. I was quite impressed, really tidy. You can see that it is old buildings, but the person that showed us around was really, really pleasant. She took us all around, and the one question we asked is, what would you change? And she said more space. So they're full to capacity. They've got 2 pop-up fridges which are full. The freezers are full. They're just really full. And the post-mortem room is quite old, but everything was really, really tidy. And even as we were leaving, they were coming in to clean again. I was quite impressed. Having never been to a mortuary in this country, I was really impressed with it. And the way it was organized. she described working across site, and for them that wasn't a problem. Being on call 24 hours as well for any issues that arise. The fridges were all working, and we were able to talk that through. So generally, I was quite impressed by what we're doing.
Ian?
Right. I mean, I think there was an air of calm efficiency about the place, and what clearly was stretched conditions, and I suppose it reflects what's going on in the rest of healthcare at the moment. And one of the problems they've got is that the undertakers don't have capacity to take bodies off site, so they get backlog that's coming in there. She was delighted that we'd gone to visit the mortuary, that felt perhaps neglected by visits. There was enthusiasm there for it. Very stable staff, so she'd worked there for 20 years, as had most of her colleagues, and it seemed to be a very stable, happy team.
Good, thanks very much. By the way, everyone, Arlene is our Chief Nurse Designate, and has joined us and is working with Charlotte for a few months, and then when Charlotte retires, in June, Arlene will take over as Chief Nurse, just in case. I'm sorry, I thought that you might have known this from last month's meeting, which I unfortunately couldn't attend, but anyway, welcome Arlene, and thank you for visiting the mortuary as one of your first tasks.
Can I just ask a quick question?
Yeah.
But how many deaths do we typically, on average, have in each of the two sites? And what's the uptick over this winter period?
Okay, so it's 120 per month across two sites, split 2/3, sort of 1/3. So say four deaths a day, split across the two sites. But there were days in January, which we've referenced previously, and this is pictured nationally, where up to 15 deaths per day. And that's up to 15.
So Public Health England yesterday published the national number of people who died in the first 6 weeks of the year, and it's over 10,000. And
it's over 10,000 more than normal.
It's 10,000 more than normal, yeah, right. It's huge, at any rate.
It wasn't just 10,000, that would be very low.
Okay.
It was 10,000 more than normal in that first 6 weeks.
So there was always a spike in January, as one would expect, both December and January. I think what the visit highlights is that our mortuary, where our staff actually have to say very family, they're very family focused, very, very empathetic, but the capacity they have isn't really built to deal with surges such as we see in the NHS on a national basis.
Good, thanks. We have one final visit. Peter and Chris went to outpatients.
Yes, so we tried to go to the Ferguson House as our mainstay of outpatients. Unfortunately, we couldn't go there because the fire alarm was activated. So it was above the main floor, but it was trickling down through. So the outpatients. So
is there something wrong with the fire alarm? I was here yesterday in Ferguson House, and the fire alarm went off.
Thursday's usually test day.
So we left, and then so we went somewhere else. We went to the I unit.
Oh, that's good.
They've got outpatients, and so the carers and patients I spoke to were all very positive about the care and support they were getting, and how quickly they were being seen. There were some issues around parking and navigation, which Chris will touch on in a bit more detail. One of the staff members I spoke to was relatively new to the trust, was really excited to be one of our new nursing associates on the training programme, so she's clearly really enthusiastic, but did comment that in the I unit she felt that they didn't have enough kit, even the basics of the kind of the eye shields or the pressure testing to actually do their job as effectively as they could, but we were clearly recognising that our building infrastructure is old. They were much patients were really confident that kind of when they got to the I unit, it was clean, it was calm, it gave you confidence that this was, you're going to get good health care, as opposed to looking on the outside in, maybe not quite the case.
Chris, you want anything to add?
A little bit. So I mainly had the task of talking to the patients and the perceptions that they were taking. So a few things that came up. Firstly was getting around the place, the signage really. With all the building work that's going on, people were struggling to know where to go. Trying to find pharmacy was mentioned, in particular, also where to go for blood tests. So that was felt as being a problem, particularly for people who'd be returning. It's just things had moved and they didn't know where. The issue of disabled parking spaces was brought up. Is that there's a limited, the number of disabled parking spaces we get to is now has been limited by the building works now. There are more disabled parking spaces that are behind a barrier. Now you can get a refund, etc., but apparently, but it's difficult for people are put off by the whole idea. So that was a bit difficult. There was a number of the receptionists talked about, and the receptionists were saying that they get 2 or 3 complaints a day on the issue of disabled parking. That was a bit
So the problem is that it's not that there isn't any, but you have to go into the barrier car park to find the disabled space and then get a refund.
No. So
Right.
we have to clear this up. There is nothing that says disabled people don't pay for car parking, right? So we have more disabled spaces than the rules say we should have, but we've had to move them because of the building work into the visitor car park. And part of the reason for expanding the visitor car park was so that we could have more visitor spaces and put a whole row of disabled spaces into the car park. That's what we've done.
I guess there's a bit of a communication flow issue through the reception studies. I think the speed of pharmacy was mentioned, with people talking about a 2-hour wait, recommendations. I think the final point, the observation I had was more of an efficiency observation. There were 9 to 12 people waiting on this clinic. There were 2 people on reception, 1 patient administrator. So there were 3 of them. They, to be honest, were struggling for things to do.
Sorry, there was one that I forgot to mention, which is a theme. So I went round the back to some of the treatment rooms, which were open and unused, and some of the drug cupboards were unlocked.
Oh no.
So I followed that through.
Good. Thank you for that. Yes. Talking about car parking, have you noticed we've now got some charging points for your electric vehicles?
Yeah.
So if you've got one, it's very useful to have a charging point. Good. Thank you very much. We've got a few minutes left, so David.
Yes, just a quick point. With the need for the NHS organisations to have a freedom to speak up guardian, what has taken place with the trust?
Who wants to talk about that? Because we do have 2.
We've got 2 freedom to speak up guardians. First of whom has been in post for well over a year now, and has been joined by a partner. If you walk around the trust, actually there's quite a lot of posters around advertising the service, which incrementally, she has more people coming to see her on a month-by-month basis, hence the appointment of a second person. A really invaluable resource for us as an organisation, for our staff, and I think what we'd say is she gets feedback and actually there are things raised with her which would not be raised or would not have been raised without that infrastructure in place.
Can I add to that? That she also has, I see her on a regular basis, and she has access to me if there's anything that concerns her about the way the response that she gets. And she's also linked in with the Command on Freedom to Speak Up Guardians and the National Guardian Office.
We actually had an external review of our service last year, which was broadly complimentary.
Good, thanks. Bess?
I think this one's for Ruth.
Okay.
I attended the meeting recently, as you know, and you spoke about sepsis. And I thought it'd be nice for people present to know that you had a doctor here, was it for a year? And now you've got 2 nurses. Is there one on each side? Because I thought that was a very interesting...
So the meeting Bess is referring to is a meeting which we held with stakeholders to discuss the quality priorities for our quality account next year. And it was great to have such an animated conversation on sepsis with a wide range of audience. What we referenced is that we did have a doctor leading on sepsis who was what's called a Darcy Fellow. A junior doctor comes along as part of their training to do like an out-of-programme experience and something different. She has left, and the positive news is that our head of nursing and medicine had appointed 2 nurse educators, one on each site, who have picked up the sepsis mantle. And given that the group and the discussion endorsed that we keep sepsis as a clinical priority for 18-19, we'll be working with them to develop a very clear work plan to identify what further steps we can take to improve the outcomes for patients who present to us with sepsis. We have seen, through the work done previously, a very significant reduction in the mortality of the very sickest patients with sepsis that require admission to our intensive care units, but as always we know there's more to do.
And then I'm disappointed that Daniel didn't put this in his weekly news, or perhaps I missed it, but it talks about prostate cancer.
I put that in my weekly news. Yes, I've done that.
I didn't see it.
Yeah, this is rapid, isn't it?
Yes,
so this is massively exciting.
And it's been expanded to Epsom.
It hasn't been expanded to Epsom. Epsom is one of the 3 pilot hospitals in the country doing it.
It's expanded to Epsom in November.
So this is very exciting. So this is a completely different way of thinking about I should have put this in my strategic update. You're right, it's very significant. How to diagnose people with prostate cancer. Traditionally, it's a really complicated, convoluted process that takes weeks. And a bunch of clinicians from Epsom, Stephen Gordon, and Imperial, and Roehampton Hospital, part of St George's, have been piloting a brand new way of doing this using MRI and a different kind of way of doing biopsy, where you can do the whole diagnostic in one day. And the NHS nationally agreed to fund the pilot because we've had to spend hundreds of thousands of pounds on new bits of kit to do the tests. And the initial results from the pilot are you really can diagnose someone to give them a yes you have or no you haven't got prostate cancer in a day. So it's all massively exciting and will probably lead to a rollout across the country. But one of the things that's most exciting about it for the NHS is this will be a first for the world. And actually, because historically the NHS isn't very good about taking innovation and saying, let's give it a go. We normally go through years of convoluted process before the NHS says yes. And this time, the NHS has said, this looks like it has a spectacular chance of being good, so we're going to back it at the beginning. And in part, the way the NHS has managed to move so much more quickly than normal is because there's something called RM Partners. And RM Partners is Royal Marsden Partners, and it is every hospital in West London. So every hospital from Harrow down to Sutton and out to Heathrow is part of RM Partners. And we said, as a group of hospitals, we can transform cancer care. And we put it, so it's like the government's vanguard programs of identifying good practice. Well, RM Partners is one of them. And it's been given a slug of innovation money. And RM Partners decided this was something to spend its innovation money on. So we essentially bypassed huge amount of NHS bureaucracy, and the providers themselves have given us a slug of money, and they chose to do this, and it looks like it's massively successful.
Good.
Thank you. And then the ECG machine keeps breaking down in the pre-assessment, and they've asked me. They've said that they've had it 20 years. Are the trust going to buy a new one? Because especially since it's pre-assessment.
So we absolutely need to have an
Yeah.
ECG machine. We've got lots and lots of ECG machines, so we will take that away. It's not an issue we were cited on.
And I was very, very concerned that in that bad snowy weather, especially on the Wednesday, patients were being wheeled across in wheelchairs in flimsy attire. Now that's not patient first. That's terrible. These are sick patients. They're being taken out in the cold and covered in snow. And one lady came up and complained to me.
So that's not so good, but what we can tell you that is positive is that I'm hopeful in less than 2 years we will have constructed a bridge between Wells Wing and Langley Wing, so that we'll end this issue of having to go outside. But that turns out to be, as ever in capital schemes, an absolutely massive amount of money to make it happen. But we've got it in the plan for one of the things that we're going to do in the next 2 years.
And then the ultrasound machine that's in paediatrics has to now be wheeled across from Wells to Langley and back again. and the manufacturer's not happy because it's taken out in all weathers, and that uneven surface could damage the ultrasound machine, so they need a second one.
Or it could live actually in outpatients potentially, where it's
Sorry?
used. It could actually be kept in outpatients, where it's
so
used
they
most
need
of
it
the
in
time.
the wards as well.
Occasionally.
So-
But let's good
work
point.
through it.
Let's work through a solution on that.
And perhaps a step could be put up because they have to get someone who's waiting for the shuttle bus to help them lift it onto the curb. And how much rent are WH Smith and M&S paying?
So they're paying. So in order to work it out, we went and asked for a commercial valuation about what should retail space in our hospitals be worth. So we had a number, and I can assure you that Marks and Spencers and Smiths are paying well above what the commercial valuer said was right, and there is a profit share as well that comes back to us. So we think that we have agreed a fantastic deal for us.
Is it paying as much as the charities would raise because
It's paying lots
you know,
more.
they've got prime spot?
Yeah. So one of the conversations was what is the impact, and the rent is way more than what the charities were able to raise.
And you know, you've moved paediatrics, but everything was very compact in one corridor, and now it's split.
Yes. So if you ask people what's the experience like, Ruth works in it. It is now way better to see patients in than the previous space was. Wouldn't you say?
Twice as many rooms.
Yes, but I mean they're not all close together, are they?
The clinic rooms are.
If the ECG, they've got to go from the front of the hospital to the back for ECGs.
I think for the vast majority of patients, you know, and there have been some signing issues, but for the vast majority of patients, now that's resolved, they come in and say, what a positive transformation, being really well received.
So the
That's not
outpatient.
what I'm hearing.
So the outpatient space at Epsom
Yes.
was absolutely appalling and still is appalling. We have patients waiting in corridors because there's no waiting rooms. So one of the things that we are doing is spending lots and lots of money on the Epsom site to move all the outpatient areas into places that actually fit for purpose to be outpatients in. Now, because we don't have a brand new building, it is going to mean that there are going to be different outpatient areas in different buildings. So they will be geographically further apart. But when you get to your outpatient space, it will at least feel like you're in a space that was designed to be an outpatient space, as opposed to sitting in a main hospital corridor, which we all think is terrible. So, because we're in the process of converting the whole of the first floor of Woodcote Wing into outpatient space.
What's the
too.
lift going to be like? Because it was very antiquated.
So there's a brand new lift in the building. Good.
So who is the Marks and Spencers for, please?
Well, it's for patients and staff.
Patients and staff?
Yeah.
Okay. And so, I think, is there a possibility of problems? There's going to be more stuff coming into the hospital. You're going to have more deliveries. You're going to have.
So the deliveries are all sorted. We've part of the.
Okay, I
I've
understand
just
that.
seen
I
it,
understand
though.
that. What about cross-infection?
Open fire doors and everything. It's terrible.
There's always teething problems with everything that is new. But if you look at the number of Marks and Spencers in the Epsom area, there are now 4.
There's one down the road, 200 yards away.
So I'm absolutely sure that Marks and Spencers think that the market for the Epsom Marks and Spencers is people on the Epsom Hospital site, and it is not going to be for making a retail shopping mall where people come to Epsom Hospital to go shopping. I don't think that's the plan.
No, the hospital is there for
being a
patients.
hospital. Yes.
Yeah.
Yeah, that's
and
right.
Staff, all right, and staff.
And visitors that come.
Sorry,
and
and you.
visitors that and visitors that come to see their patients.
I don't think anybody wants to pay £4 an hour to go to Marks and Spencers.
But we're not suggesting that they would. It's for people who are coming to visit their patients, families, people who use outpatients, the staff.
All right.
So
I'm pulling your leg
I
slightly, but I'm saying it even so.
I came from a trust where we opened one about 6 months before I left, and it was seen as the biggest and best thing that happened for patient welfare and staff welfare in a long time. It was really well received.
Fantastic. I'm delighted to hear it.
Good. We've got a couple of minutes left, so Sandra.
I remember in 2005 2015, Daniel promised, told the campaigners, put your banners away. All of the acute services were going to stay exactly as they are in both Epsom and St Helier, and you've repeated it several times since, Daniel.
Yeah.
I've been told this morning that the A&E, the full A&E, has now been removed from Epsom Hospital. Is that true?
Completely not true. It's what we said in 2015, it was true in 2016, true in 2017, is true in 2018, will be true in 2019, will be true in 2020, and then we said, since we're still on track for actually getting a brand new critical care hospital, but it'll take till the mid-2020s, we gave everyone the commitment to say, we'll keep everything going until we get to that. So Epsom still has a red A&E sign outside it today.
People here from Epsom are telling me that's not true.
I don't know. Outside, I don't know about outside, but there's a critical care unit now.
But the level 3 ITU and emergency surgery have been provided on the St Helier site for well over a decade. Nothing has changed recently at Epsom. In fact, actually what's going on in Epsom is everything is getting bigger.
So they still have a full A&E?
If there's any confusion, it is now complemented by an urgent care centre.
It's not full A&E.
But it is.
It's not.
So do you remember in all our documentation we said there are 6 acute services? And we did little graphics for the 6 acute.
No, listen, Daniel,
right?
I know what you said, but I'm being told differently today from people who experience
Well,
it.
I'm just telling you,
I'm asking the question.
and I'm answering you very, very directly that this is not right. Of those 6 acute services, we shaded 2 in yellow, which were critical care level 3 ITU and emergency surgery, and said these 2 services are only at St Helier and have only been at St Helier for a very, very long time. So nothing has changed this year, last year, the year before.
Apart from the addition
Apart
of an
from
urgent care centre.
Yeah.
Do you think it was because now they've changed the entrance, it's better, but when they came in before, they came in the door and the sign saying A&E was right in front of them.
So we haven't finished yet.
No, but people didn't see that. It was right in front of them.
But the thing that strikes me when you now go to the entrance is the sheer complexity of the urgent care system we have designed, because it says A&E, it says urgent treatment centre, it says GP out of hours, and it says ambulatory care, right? And that's because currently there are 4 different emergency things, right? The thing that is being really successful at Epsom is we're co-locating them all in the space that is A&E, so that everyone can work together rather more effectively.
Would you believe when they came in that door, you couldn't miss it, but they still turned left. It's different now because they've made the 2 entrances.
Yeah, but we haven't finished yet.
No,
so
I know,
so to get into A&E is still going through a bit of a building site. But when it's finished, it'll be really obvious where the A&E entrance is.
Fine. Very quick, Dave, and then we've got to finish at 11.
It's a shame it's got to be quick because they're rather important questions. Coming back to all that was said about mortality earlier, there's a gaping hole, as I see it, in your risk report. We had 68 senior A&E consultants write to the Prime Minister about trolley waits, premature deaths caused by lack of beds. We had 200 people waiting for an ambulance because they couldn't be released, because people couldn't be admitted to St Helier. You have inadequate beds. Now, I would like to see your risk report include not just those mortalities that occur to patients who are in your care, but also to those patients that you have been unable to admit for care because of your inadequate capacity.
So you'll notice that our clinicians didn't sign that letter. And the reason why they didn't sign that letter is because we have worked so collectively hard to ensure that in this huge increase in activity, which is unprecedented, we have done our level best to manage the capacity well.
I'm not commenting on your staff, I'm commenting on your capacity, which is inadequate, and that was reflected in the comment in one of these 15-step challenges at a previous meeting, where A&E reported that they were unable to admit patients who had been transferred here from St George's because of your lack of capacity. There weren't beds for you to move people out of A&E, so the A&E was clogged up, so people couldn't get out of ambulances, so people couldn't have an ambulance go to them because they were at the hospital with a patient in them. So you really ought to be reporting who dies because of your lack of capacity.
So we need to do the mortality review, but currently we don't think anyone died because of the lack of capacity.
You know.
Sorry. Well, that's why we're doing.
That's why. So if you look back to the performance report, which I went through, and you look at the mortality domains, it references the increase in death rate nationally and locally in January, and references that we're actually doing an in-depth analysis, mortality reviews, to ensure that any learning to be taken from that period is taken on board.
My comment is you're only reporting on patients who are in your care. There are many patients who don't make it into your care.
Okay, so our responsibility is obviously for the patients in our care. We're not reviewing, and I take the point, the wider system. We can only review the patients, be they in A&E, on the acute medical unit, or any ward in our hospital that has died in January. That's what's beholden on us to do, and that's what we're undertaking.
I think it's beholden on you to demand an adequate provision of capacity. Anyway, that's enough time on that, because I know you're in a hurry to go away. The other thing I want to ask about is your relationship with the Sutton Conservatives and Paul Scully MP. Because Paul Scully has, on national television and in other media, more than once said how closely he is working with the chief exec, as he calls you, Daniel, and has been putting out misrepresentations of your plan and your findings in your engagement through people's letterboxes across Sutton. He has said, a step closer for a new hospital for Sutton. It is not a hospital in your plan, it's a facility. There is no new hospital on offer. You have not said that it will be in Sutton. You said you've had a consultation. You haven't had a consultation. And he said there's overwhelming public support. You only got 1,059 responses and only 441 identifiable people saying that they liked the idea as it was presented to them inadequately by you. So are you going to make any public correction to the misrepresentation of your activities by this MP?
So I think that's a question for you to ask Paul Scully.
No, I'm asking you if you're going to correct what he said. He's claiming that you have said various things which you haven't said. You have a right to reply. I think you've got a duty to reply.
So I spend lots of time with all of the politicians who represent the communities that we provide healthcare to. And I spend lots of time with Siobhan, and with Paul, and with Chris, and with Crispin, and with Tom, and we give them as much access as they would like to us, to talk to us, see things for themselves. How they all take that information and talk to their constituents is for them as politicians, not for me as the chief exec of the hospital.
He is giving the public the impression that you have said something that you have categorically not said. He is misleading the public about your plans, intentions and findings. You've got a duty to correct that.
So we have a duty.
Especially, as you just said, you spend a considerable amount of time with him. Is the man stupid, or is he a rogue?
So we have a duty to explain to the public what it is we would like to do and be open and transparent about it. That is what I think we have done really quite successfully. It is for the politicians to decide how they want to use the information that we put in the public domain. That's as far as it goes.
Your information. He is distorting and misstating your information.
Well, I could. So look, I could, if I'd wanted to, challenge the literature that Kosh have put out, which show me in an unflattering light on a wrecking ball. Right? I haven't, because I think that's your decision on how you communicate with it. Well, I think I could make a pretty good case that I have never said that I want to sit on a wrecking ball and destroy St Helier Hospital. So
we never even wrote the name on it. If you choose to think it's you, that's fine.
Right, thanks very much, everybody. Thanks, I think that's a good time to end. And we'll see you in April in Epsom. Thanks very much.